Hello students, welcome to this session in abdomen. In this session, we'll be discussing about the blood supply of gastrointestinal tract, including the artery of the foregut, the celiac trunk, the artery of the midgut, the superior mesenteric artery, the artery of hindgut, the inferior mesenteric artery, and also about the portal venous system. Shall we start? So, can we identify the abdominal aorta here? From the ventral surface, three branches, right? This is the celiac trunk that is going to supply the derivatives of the foregut. Lower end of the esophagus, the stomach, the duodenum up to the opening of the major duodenal papilla, and also the liver, the gallbladder, the pancreas, and also the spleen, though it is not a derivative of foregut. Okay, and then this one here is the superior mesenteric artery. The superior mesenteric artery is going to supply the structures derived from midgut, that is the rest of the duodenum below the opening of major duodenal papillae, the jejunum, the ileum, and then yes, the cecum, appendix, ascending colon, and up to the right 2/3 of the transverse colon. This one here is the inferior mesenteric artery, which is going to supply the derivatives of hindgut, that includes the left 1/3 of the transverse colon, the descending colon, sigmoid colon, and the rectum, upper part of the anal canal up to the pectinate line. Okay, come on, let's see. So let's start with the celiac trunk. You should be able to identify the celiac trunk in the cadaver in an image-based question. So you know that it arises from the aorta, ventral surface of aorta. And as I told you, it is going to supply the derivatives of the foregut plus the spleen, pancreas, liver, gallbladder. Yes. And as it comes from the anterior surface of the abdominal aorta, its origin is immediately below the aortic opening and corresponds to T12. Okay. It has a very short trunk. As you see here, it is very short trunk, 1.25 centimeter, and then it immediately divides into three branches. This one going upwards and to the left here. This is the left gastric artery. Okay, this is the smaller of the three branches. And this one here going towards the right, it's the common hepatic artery. The largest branch of the celiac trunk, which is tortuous, easily identifiable, is the splenic artery running along the upper border of the pancreas. Okay, now, as soon as the celiac trunk arises from the anterior surface of the abdominal aorta, we can see that it lies behind the omental bursa. So anteriorly, it is related to the omental bursa or the lesser sac, the part of the peritoneal cavity behind the stomach, isn't it? And here, okay, you see the pancreas. This part of the pancreas which lies below the origin of the celiac trunk, it's called the tuber omental. Above, it is going to be related to that part of the liver that gives a projection, the papillary process of the caudate lobe. It is going to be surrounded by the celiac plexus of nerves. Fine. Let us go into the details of each branch. Come on, let us identify the left gastric artery. This is the left gastric artery. This left gastric artery, as you see here, it turns upwards and to the left. It lies beneath the superior gastropancreatic fold. You can see it running along the lesser curvature of the stomach. What is the ligament that is related to the lesser curvature? The lesser omentum. And along the lesser curvature, within the lesser omentum, this left gastric artery, it terminates by anastomosing with the right gastric artery. Fine. This left gastric artery, it supplies major part of the stomach, the upper two-thirds of the stomach, though it is the smallest of all the three branches. It also supplies the lower end of esophagus. We can see the left gastric artery running along the lesser curvature, isn't it? And we know that the ulcers of the stomach are more common along the lesser curvature. So if these ulcers perforate, yes, they can result in bleeding from the left gastric artery. Moving on to the next branch. Yes, this is the common hepatic artery. This common hepatic artery, again, it lies, behind the omental bursa. We can see it running to the right along the upper border of the neck of the pancreas, right? The common hepatic artery here. Yes. And this one, it is going to be related to the inferior gastropancreatic fold. This common hepatic artery will give rise to hepatic artery proper. The hepatic artery proper, you can see here running along the free margin of the lesser omentum, just to the left of the common bile duct. This one. Okay. And then it gives the right gastric artery. This right gastric artery, it enters the lesser curvature to anastomose with the left gastric artery. One more branch going behind the first part of the duodenum, behind the head of the pancreas. Yes, come on. What is this one? The gastroduodenal artery. So these are the three branches arising from the common hepatic artery. The hepatic artery proper that we see here, it is located in the right free margin of lesser omentum. We know that this lesser omentum is a derivative of the ventral mesogastrium. It extends all the way from the liver to the lesser curvature and the proximal part of the duodenum, isn't it? This is the lesser omentum. The attached margin is to the lesser curvature and the proximal part of the duodenum. This is called as the free margin of the lesser omentum. And this free margin of lesser omentum has three important structures. This green color which we see to the right is the common bile duct. This one to the left, that's the hepatic artery. And just between and behind these two, we get to see the portal vein, right? And we know that the right free margin of the lesser omentum with these three structures forms the anterior boundary for the epiploic foramen. Okay, so if I put my fingers behind these three structures, I will enter the epiploic foramen, which will take my fingers to the lesser sac, the peritoneal cavity situated behind the stomach. Okay, so as we have seen here, it is accompanied by the common bile duct to the right and the portal vein behind. This hepatic artery proper, as you see here, it is going to divide into a right and left branch. So this is the right and this is the left hepatic artery. Okay, the right hepatic branch will also give rise to cystic artery that supplies the gallbladder. And then this right hepatic branch will enter the right lobe of the liver. The left branch will enter the left lobe of the liver. Okay, remember the main blood supply to the liver is coming from the portal vein. 80% of the blood supply is from the portal vein. And the remaining 20% is by the hepatic artery. Coming to the right gastric artery, this is the right gastric artery. Okay, the right gastric artery. As you see here, the right gastric artery, it runs downwards to the left to reach the lesser curvature, where within the lesser omentum, it anastomoses with the left gastric artery. Fine. Coming to the gastroduodenal artery, an important branch from the common hepatic artery. So this gastroduodenal artery that you see here, It runs behind the first part of the duodenum, behind the head of the pancreas. It is going to divide into the right gastroepiploic artery. The right gastroepiploic artery is the one that you see here. Yes, it runs along the greater curvature within the greater omentum to anastomose with the left gastroepiploic artery, a branch of the splenic artery. Okay, so that's the right gastroepiploic artery. And then this gastroduodenal artery will give rise to the superior pancreatico-duodenal artery. This superior pancreatico-duodenal artery that you see here, yes, it runs between the second part of the duodenum and between the head of the pancreas. It will anastomose with the inferior pancreatico-duodenal artery, that's a branch from the superior mesenteric artery. And from this anastomosis, branches will arise to supply the anterior and the posterior surface of the duodenum as well as the head of the pancreas. Occasionally, this gastroduodenal artery will give rise to supraduodenal artery, or it is also called the artery of Wilkie, which supplies exclusively the first part of the duodenum. And please remember, this supraduodenal artery is an end artery. It terminates by supplying the first part of the duodenum without forming any anastomosis with the neighboring arteries. So that was all about the common hepatic artery. Now moving on to the splenic artery. As I told you, this is easier to identify in the cadaver. It is the largest branch of the celiac trunk. It has a tortuous course. There are very few arteries in the entire human body which have a tortuous course. So here in the abdomen, we got to see the splenic artery, and in the pelvis, we'll get to see the uterine artery. In the head and neck, we have the facial artery. And within the cranial cavity, we get to see the postero-inferior cerebellar artery supplying the medulla and the cerebellum. These arteries, they have a tortuous course. Okay. So this splenic artery that you see here, you can see it running along the upper border of the pancreas. Along with the tail of the pancreas, the splenic artery, it lies within the lieno-renal ligament, which is in contact with the hilum of the spleen. Fine. The splenic artery will give rise to, so you can see it running behind, right? I'm showing it as a dotted line. It is related to the omental bursa, relation for the postero-inferior surface of the stomach, right? It forms one of the structures for the stomach bed. Okay, so this is the short gastric vessels arteries that arise from the splenic artery to supply the fundus of the stomach. And then it will give rise to the left gastroepiploic artery. This left gastroepiploic artery, it runs along the greater curvature of the stomach within the greater omentum to anastomose with the right gastroepiploic. And then we get to see a lot of branches coming from the splenic artery behind the stomach to supply the pancreas, the pancreatic branches. Okay, few of them like the arteria pancreatica magna is one larger branch that accompanies the main pancreatic duct. And then we have caudal pancreatic artery that supplies the tail of the pancreas. And there's one more dorsal pancreatic artery that supplies the posterior surface of the pancreas. Not to forget, this splenic artery will give rise to the splenic branches that supply the spleen. And please remember, these splenic branches are again end arteries. All the other branches of the splenic artery that we see here, the short gastric artery, the left gastroepiploic artery, the pancreatic artery, okay, they'll be anastomosing with the neighboring arteries. But the splenic branches of splenic artery are exclusively end arteries. We saw that it forms one of the stomach bed structures. So, a ulcer in the posterior wall of the stomach can erode the splenic artery, leading to severe hemorrhage. Now, yes, we have completed celiac trunk. What are the three branches of it? The left gastric artery, common hepatic artery, and the splenic artery. Moving on to the artery of the midgut, the superior mesenteric artery. Can you identify the origin of superior mesenteric artery here? Yes. So this is our superior mesenteric artery. It is arising from the ventral surface of abdominal aorta. And its origin, it corresponds to vertebral level L1, transpyloric plane. See its origin, very important relations are there. This vein related above is the splenic vein. This vein, which is related below the origin of the superior mesenteric artery, is the left renal vein. And you can see that the body of the pancreas has been removed to show the origin of superior mesenteric artery. So this origin of the superior mesenteric artery, it lies behind the body of the pancreas, below the splenic vein, above the left renal vein. Important relations. And we can see that the course of the superior mesenteric artery is very interesting and important. We can see that this artery, yes, it runs downwards to the right. The superior mesenteric artery, it lies within the root of the mesentery, accompanied by the superior mesenteric vein along its right side. And it is going to cross, as you see here, the third part of duodenum, the abdominal aorta, the inferior vena cava, the right psoas major, the right ureter, the right gonadal vessels, and reaches the right iliac fossa. Okay? Branches coming from the superior mesentery. Come on, let's identify. This is our superior mesenteric artery, isn't it? The very first branch of it, come on, you can see here, it is the inferior pancreatico-duodenal artery. As I told you, this inferior pancreatico-duodenal artery, yes, you can see it like related above the third part of the duodenum, and then it ascends up in the groove between the second part and the head of the pancreas to anastomose with the superior pancreatico-duodenal artery coming from the gastroduodenal artery. Okay. And then, yes, from the left side of the superior mesenteric artery is convex. It is going to give rise to branches to supply the jejunum and ileum. They are called the jejunal and ileal branches. These jejunal branches, you can see they are like forming arterial arcades. In the jejunum, there are 1 to 2 arterial arcades, and the vasa recta arising from these arterial arcades are longer. Okay. So these are the jejunal branches. You can see them forming the arterial arcades, and the branches coming from the arterial arcades to supply the jejunum, they are called vasa recta. They are longer. Whereas in the ileum, if you see, the branches, they anastomose forming 2 to 6 arterial arcades. And the vasa recta coming from these arterial arcades, yes, vasa recta coming from these arterial arcades are shorter in size. So we saw what is the first branch, and then we looked down to the jejunal and ileal branches. Now come on, let's identify the branches on the right side of superior mesenteric artery. This one that we see here is the middle colic artery. From the superior mesenteric artery, this middle colic artery will divide into a right branch and left branch. And this one here, it is the right colic artery. This right colic artery will divide into an ascending branch and descending branch. This ascending branch, it goes ahead to anastomose with the right branch of middle colic artery. And then this one here is the ileocolic artery. Okay, and this is the termination of the superior mesenteric artery. And please remember, this terminal part of the superior mesenteric artery, it anastomoses with the ileocolic artery to complete the anastomosis running along the large intestine. Okay, so yeah, this ileocolic artery, the branches from the ileocolic artery are important. The ileocolic artery again will divide into an ascending branch. This ascending branch will anastomose with the descending branch of the right colic artery. And then after that, okay, the descending branch of the ileocolic artery is going to further divide into anterior cecal artery, posterior cecal artery, and the appendicular artery. Also, it will give rise to a branch that supply the terminal part of the ileum and also another branch to supply the ascending colon. So, these are all the branches of the ileocolic artery. The anterior cecal artery, it will lie in the superior ileocecal fold. Okay, the appendicular artery you can see here. This is the appendicular artery, and that peritoneal fold in which it lies, it's called the mesoappendix. This appendicular artery will try to reach the tail of the appendix close to its tip. The tip of the appendix is the least vascular. Another thing to remember is that similar to supraduodenal artery, similar to splenic branches of the splenic artery, this appendicular artery is also a end artery. So, occlusion of this appendicular artery, then the area supplied by it can go for ischemia and necrosis. So, that was about the superior mesenteric artery. Now, let us move on to the inferior mesenteric artery. Where to look for the inferior mesenteric artery? This is the inferior mesenteric artery. The inferior mesenteric artery, it arises from the ventral surface of abdominal aorta. Opposite the vertebral level, yes, celiac trunk was T12, superior mesenteric artery L1, transpyloric plane. This one L3, subcostal plane. Okay, and it runs downwards and it lies to the left of the abdominal aorta. Its termination is interesting. This inferior mesenteric artery, it runs to the left of the abdominal aorta. It enters the lesser pelvis by crossing the left common iliac artery. This is the ureter. The left ureter, it enters the lesser pelvis, crossing the left common iliac artery, medial to the left ureter. And you know what? Can you tell me what is this viscera? It is the rectum. You can see it going behind the rectum. Yes, this inferior mesenteric artery, it terminates by continuing as the superior rectal artery. Okay? Branches coming from the inferior mesenteric artery, let us identify. So, this is the left colic artery. The left colic artery will divide into a ascending branch and descending branch. The ascending branch will anastomose with the left branch of middle colic. Okay, and these are all the sigmoidal branches of the inferior mesenteric artery to supply the sigmoid colon. This is the superior rectal artery. So, usually what will happen is that this lower sigmoidal artery, it will anastomose with the superior rectal artery to complete that anastomosis. Okay, come on, let us look into some interesting features in the blood supply of these arteries. Okay, So as we see here, this arterial arcade that extends all the way from the ileocecal junction to the recto-sigmoid junction to supply the colon. Yes, between the colic branches of superior mesenteric artery and the inferior mesenteric artery, it's called the marginal artery of Drummond. Okay. Now, what is this critical point of Sudak? Just now I told you the lowest sigmoidal artery, what happens? It has to anastomose with the superior rectal artery to complete this anastomosis. If it fails to anastomose with the superior rectal artery, then that point is called as the critical point of Sudak. Arc of Raylan. So we know that there is anastomosis between the colic branches of the superior mesenteric artery and inferior mesenteric artery. There, retroperitoneally, there can be an anastomosis between the trunk of superior mesenteric artery and inferior mesenteric artery. This is called arc of Raylan. Griffith point is very important. It refers to the splenic flexure or the left colic flexure, which is the watershed area. So up to right 2/3 of transverse colon, you know, it is the superior mesenteric artery, and beyond that it's going to be inferior mesenteric artery. So this is at a crucial junction between the territory of superior mesenteric artery and the inferior mesenteric artery. Okay, it is vulnerable for ischemia and necrosis. Yes, it is called the Griffith point, corresponding to the splenic flexure or the left colic flexure. Dunbar syndrome. So here, come on, this is the celiac trunk. How does the abdominal aorta enter the abdominal cavity? Through the aortic opening, isn't it T12? Yeah, this is the right crus of the diaphragm. This is the left crus of the diaphragm. Bridging both. Yes, this is the median arcuate ligament. The space that we see below the median arcuate ligament is the aortic opening of the diaphragm through which the abdominal aorta enters the abdominal cavity. And what are the structures accompanying it? The azygos vein and the thoracic duct. They leave the abdomen to enter the thoracic cavity, isn't it? Okay. So normally the origin of the celiac trunk, it corresponds to T12. It lies immediately below this aortic opening. Sometimes what can happen? The median arcuate ligament can compress the origin of the celiac trunk. Okay. And that condition is called as Dunbar syndrome, and then there's going to be reduced blood flow through its branches to the foregut. Dunbar syndrome. What is Wilkie syndrome? So this, what we see here, is the abdominal aorta. Can you tell me what branch arises from the ventral surface of the abdominal aorta opposite L1? The superior mesenteric artery, isn't it? So between the abdominal aorta and the origin of the superior mesenteric artery, we get to see three important structures. This one here is the left renal vein. And below that, it's the uncinate process of pancreas. This is the third part of duodenum. Okay. Now, what is the problem is that when the angle between the abdominal aorta and the origin of the superior mesenteric artery is going to get reduced, then these structures that lie between the two can get crushed. Hence, it is called as the nutcracker syndrome. It is also called the superior mesenteric artery syndrome. So that will lead to varicocele on the left side. We know that the left renal vein, it receives, yes, the left suprarenal vein from above and the left testicular vein from below. The left testicular vein, how is it formed? by the union of the pampniform plexus of veins in the spermatic cord that drains the testes, isn't it? Okay. So if there's going to be an obstruction of the left renal vein, then the blood is going to, yes, accumulate in these veins, giving it a tortuous appearance, bag of worm appearance called the varicocele. Okay. And then duodenal obstruction is present in this superior mesenteric artery syndrome. Calot's triangle. So the Calot's triangle, it is bound on the right by the cystic duct, on the left by the common hepatic duct, above by the cystic artery. This Calot's triangle has the cystic node of Lund. So the cystic artery, which is coming from the right branch of the hepatic artery, isn't it? And what is this? A tortuous caterpillar-like hepatic artery, the right branch of the hepatic artery. Sometimes, yes, it can be abnormally dilated and tortuous, okay, and that is called as the Moynihan's hump. If accidentally injured, that can lead to severe bleeding. Now, moving on to the last topic in this session about the portal vein, okay. So come on, tell me. The portal vein is going to drain the venous blood from the abdominal part of the GIT. Yes, abdominal part of GIT up to the anal canal pectinate line. Okay, the part of the anal canal below the pectinate line is going to be drained by the systemic veins, right? And what type of blood does it contain? So it's not just venous blood. Yes, since it is going to drain the blood from the GIT, this venous blood is rich in, end products of digestion. Its length measures 8 to 10 centimeter and the normal pressure within the portal vein is 5 to 10 millimeters of mercury. In portal hypertension, it can go beyond 40, right? 30 to 40. This portal vein is important. Okay, so it begins in the GIT like a vein from the capillary plexus and it empties in the liver by breaking down into hepatic sinusoids. Okay, so it is beginning and end is different. You know what? 1/3 volume of total blood in the body is present in this portal vein. It has no valves. As I told you, it has venous blood which is rich in end products of digestion and 80% of the blood to the liver is brought by this portal vein. This portal vein, as you know, is formed by the union of splenic vein on the left and the superior mesenteric vein. Actually, the blood within the portal vein, it continues to remain in two streams. The right branch, it has blood from the superior mesenteric vein and it reaches the right lobe of the liver. Whereas the left branch of the portal vein, that carries the blood from the splenic vein. So any infection in the area drained by the superior mesenteric vein, it can travel to the right lobe. Okay, that's why the amoebic liver abscess, pyogenic liver abscess are more common in the right lobe of the liver. So the formation of the portal vein, it lies behind the neck of pancreas. The disc between L1 and L2 by the union of splenic vein that drains the venous blood from the spleen, from the pancreas, from part of the stomach also, isn't it? And by the union of the splenic vein with the superior mesenteric vein, the superior mesenteric vein, it drains the venous blood from the midgut part of the digestive tract. As I told you, it is going to divide into a right branch, left branch, are the porta hepatis to enter the liver. Coming to the course and relation of the portal vein. So here in this image, come on, let us identify the portal vein. This one here is the portal vein. So we saw that it's formed behind the neck of the pancreas, right? So this first part of the duodenum is an important landmark. This is the first part of the duodenum. This is second part and third part, right? Okay. So the part of the portal vein which is formed, that initial part, it lies below the first part of the duodenum. And as it ascends up, it goes behind the first part of the duodenum. And then we can see it along the right free margin of the lesser omentum. So its course can be divided into infraduodenal, retroduodenal and supraduodenal. In the infraduodenal part, so where is the infraduodenal part? Here, this is our pancreas. You can see the head of the pancreas. So the head of the pancreas, the neck of the pancreas, yes, has to be removed to see the portal vein, anteriorly related to the pancreas. And behind, it will be related to the inferior vena cava. On the right side, the common bile duct. So these are the relations in the infraduodenal part. And retroduodenal part, we see the first part of the duodenum here, right? So the anterior relation for the retroduodenal part of portal vein will be the first part of the duodenum. And to the right side will be the common bile duct. To the left side will be the gastroduodenal artery. Behind will be the inferior vena cava. Coming to the relation in the supraduodenal part, as I told you, it lies in the right free margin of lesser omentum. Okay. So we have been seeing about the structures in the right free margin of lesser omentum, the attachments of the lesser omentum, the contents, all that, right? Okay. So here, to the front, you see the portal vein, just to the front and to the right of it will be the common bile duct. To the front and to the left of it will be the hepatic artery proper. Okay, can you appreciate this green color one here? That is the common bile duct on the right. This is the hepatic artery proper. This one blue that you see here, that's the portal vein. Okay, and behind it's going to be the inferior vena cava. Okay, here if you want to see the inferior vena cava, this one behind, this is the inferior vena cava, this one in front is the portal vein. And yes, in front of the inferior vena cava, remember we have the epiploic foramen. So the portal vein, it lies anterior to the epiploic foramen, isn't it? Posterior to the epiploic foramen, we have the inferior vena cava. Come on, let's look into the tributaries of the portal vein. The formative tributaries, all of us know, it is the splenic vein. And this is the superior mesenteric vein. And then this is the right gastric vein. And this is the left gastric vein. The right and the left gastric vein, they open into the trunk of the portal vein. The right branch of the portal vein, can you see? It receives the cystic vein that drains the gallbladder. Similarly, the left branch that receives the para-umbilical vein, the left branch of the portal vein. Okay, occasionally the right gastroepiploic vein, the inferior mesenteric vein and the prepyloric vein of Mayo can open into the portal vein as its tributary. The prepyloric vein of Mayo, normally it opens into the right gastric vein. Okay, so in this image, can you see here, this is the inferior mesenteric vein that opens as a tributary into the splenic vein normally, but occasionally it can open as a tributary of portal vein. Coming to the clinical importance of this topic, portosystemic anastomosis, a very, very high topic, isn't it? So we have to know the sites where the tributaries of the portal vein and the systemic vein anastomose. Okay, these are the sides of collateral channel. So lower end of esophagus, lower end of rectum anal canal, around the umbilicus, and in the liver over the bare area, and in the falciform ligament, yes, retroperitoneally. Okay, these are the common sites of anastomosis. So at each site, now we are going to look into the portal tributary and the systemic tributary. So in the lower end of esophagus, can you tell me which is the portal tributary? The left gastric vein. Okay, so this left gastric vein at the lower end of the esophagus can communicate with the azygos vein and the hemiazygos vein, which open into the superior vena cava, right? And lower end of rectum anal canal, above the pectinate line, we have the superior rectal vein. We know that the superior rectal artery is a continuation of inferior mesenteric artery. So the superior rectal vein will continue with the inferior mesenteric vein, and that opens as a tributary of splenic vein. Here, the systemic tributary will be the middle and inferior rectal vein. Yes, which will open into internal iliac vein. Umbilicus is an important site of portosystemic anastomosis. Here, the portal tributary will be para-umbilical veins. Okay, and the systemic tributaries from above the umbilicus, it will be the superior epigastric artery, lateral thoracic artery, and from below will be the inferior epigastric artery, superficial epigastric artery, and from the sides we have the posterior intercostal veins and the lumbar veins. Okay, I'll be doing this again, no worries. Coming to the bare area of liver, here the radicals of the portal vein, they directly communicate with the diaphragmatic veins below the diaphragm. Okay, the subdiaphragmatic veins, which are, yes, tributaries of systemic vein. And posterior abdominal wall retroperitoneally, the splenic, the tributaries of the splenic vein and the colic veins, they communicate with the tributaries of the left renal vein and other communications of inferior vena cava. Falciform ligament, we have the para-umbilical veins, which will communicate with the systemic veins through the accessory portal system of Sappe. Okay, and the fissure for ligamentum venosum, yes, we have the ductus venosus, which will join to the left branch of portal vein. Okay, so the lower end of esophagus. So we saw that the normal portal pressure is 5 to 10 mm of mercury, and in portal hypertension, what can happen? The pressure can exceed. It can go up to, in portal hypertension, the pressure can go up to 40 millimeters of mercury. And through these anastomosis, yes, diversion of blood. And we know that the lower end of esophagus is another important site of portosystemic anastomosis. So the submucosal veins here, they are enlarged, dilated and tortuous. They can rupture, leading to hematemesis. What are the reasons for portal hypertension? What are the things that can increase the pressure within the portal vein? Any obstruction due to a thrombus, cirrhosis of liver, or any carcinoma compressing the portal vein. We saw that portal vein, the course of the portal vein and relations of the portal vein, right? We saw that is related behind the head of the pancreas, behind the neck of the pancreas, behind the first part of the duodenum. So carcinoma of the pancreas, a duodenal obstruction, that can compress the portal vein. All that can increase the pressure within the portal vein. Yes, lower end of the rectum anal canal is another important site of portosystemic anastomosis. So in portal hypertension, we get to see the hemorrhoids here. They can also bleed profusely. The internal hemorrhoids are seen above the pectinate line, okay, and they are painless. The external hemorrhoids are seen below the pectinate line. They are painful because that area is going to be innervated by the somatic nerves. The common position of internal hemorrhoids, yes, you can tell me, 3 o'clock, 7 o'clock and the 11 o'clock position. So what is this you see here? Characteristic of portal hypertension, caput medusae. Dilatation of the veins of the anterior abdominal wall in portal hypertension. It's called the caput medusae. Here you can see the umbilicus. So what are the veins from above? I told you from above we have the superior epigastric vein, the lateral thoracic vein, and from below inferior epigastric vein, the superficial epigastric vein, and from the sides it is going to be posterior intercostal veins and the lumbar veins. Okay, so these are all systemic veins. They will be anastomosing with the para-umbilical veins. In portal hypertension, these veins around the umbilicus, they become dilated and tortuous. The thoracoepigastric vein. The thoracoepigastric vein, it connects the lateral thoracic vein to the superficial epigastric vein. Okay, it is the only vein connecting the vein of the upper limb to the lower limb. Come on, let's work out few MCQs. The ligation of celiac trunk, it mostly affects all the following except. So celiac trunk, we know it's going to supply the derivatives of the foregut and the spleen. It supplies the stomach, the pancreas, the spleen. But the jejunum is a derivative of the midgut and it will be supplied by superior mesenteric artery, right? Let us match it. So what do we find in the right free margin of the lesser omentum? The hepatic artery proper. Superior border of the pancreas is related to the splenic artery. The vessel running anterior to the uncinate process, superior mesenteric vessels. And greater omentum, anastomosis between the right and left gastroepiploic artery. Which of the following is an end artery? The appendicular artery, the supraduodenal artery of Wilkie, the splenic branches of splenic artery are end arteries. Come on, let's answer it together. The largest branch of celiac trunk is splenic artery, which is tortuous. The first branch of superior mesenteric artery is inferior pancreatico-duodenal artery. Termination of superior mesenteric artery is that it anastomoses with the ileocolic branch. And the termination of inferior mesenteric artery is that it continues as inferior mesenteric artery. Yes, just now we did it right. What are the end arteries? The supraduodenal artery of Wilkie, that's a branch of gastroduodenal artery. The appendicular artery, it's a branch of the ileocolic division of superior mesenteric artery, and the splenic branches of splenic artery. The watershed area between superior mesenteric artery and inferior mesenteric artery, the Griffith point, it corresponds to the splenic flexure or the left colic flexure. Artery that is eroded in a posterior perforating ulcer of the stomach is splenic artery related to the stomach bed. The first part of the duodenum, yes, ulcer can occur. It erodes the gastroduodenal artery that is related posterior to the first part of the duodenum. Artery eroded in perforating ulcer of the lesser curvature, left gastric artery. Posterior perforating ulcer of the pylorus, the abscess will be formed in the lesser sac. So behind the stomach, we get to see the lesser sac. Vertebral level of origin of inferior mesenteric artery is L3. Can you tell me what plane it is? The subcostal plane. So in this session in abdomen about blood supply of the digestive tract, we have seen in detail about celiac trunk, its branches, their area of distribution, the superior mesenteric artery, inferior mesenteric artery, and also about portal vein portosystemic anastomosis. Can you tell me what is Dunbar syndrome? Compression of the celiac trunk, right, by the median arcuate ligament. And yes, can you tell me what are the branches of inferior mesenteric artery? The left colic artery, the sigmoidal branches, and then it continues as the superior rectal artery. Okay, what are the portal and systemic tributaries over the bare area of the liver? Over the bare area of the liver, the radicals of the portal vein, they anastomose with the diaphragmatic veins. Fine. Hope this session was useful. Lot of MCQs, short note, image-based questions can come from this topic. Read thoroughly. Happy learning.